lunch. We've got to get started with our afternoon session, please. We'll just go around the few times. Does this coat belong to any one of your children? Left in the restaurant? Oh, yes.
So the other way. I'm going to be back.
Hold on to it. So we're going to kick off our afternoon session with these two gentlemen. Thank you.
Okay. Everybody's coming in after lunch. It was a lovely lunch. Thank you very much for that. If anybody's sleeping, I'll be spotting you out. So this is my first opportunity. I'm called Joe Curry. I work at Great Ormond Street with Paolo and Simon. I know Jonathan Aaron very well. It's, as everybody said, a privilege to come and join you for what I hope will be the first of many, many years of collaboration, cooperation, support, help, all of the things that comes from a great day like this. Myself and Jonathan are going to do a kind of... No problem. I try not to boom in the microphone. So myself and Jonathan are just going to do a little bit of a free session for half an hour, which is going to be looking at some important questions about bowel management. Many of these questions have been given to us by Greg and were based on one of the events that occurred in Australia. So some of them will have relevance to you, but we hope that there'll be time at the end of the session for many more questions from you. And please feel free to come and grab myself and Jonathan during the later coffee break and later on in the day if you have any questions you want to put to us personally. So I said it's interactive. If you want to put your hands up at any time, ask us a question, then please do. And as inevitably, we won't cover every single thing that needs to be covered, but that's the onus and benefit of future years of our relationship together. John.
And we've planned to do this in the style of Les Dawson.
Who's he?
Oh, he's a comedian. Yeah. Right, so the idea of having families produce questions really came from Cassie. And you know that thing about a homunculus, you know that diagram that we all know of someone's brain, and the thing that's most important to you in a way is your thumb. It takes up more of your brain than maybe your little toe, yeah? So if you were to ask 10 surgeons or 20 surgeons what the most important things are, we would all come up with maybe 80% crossover. We'd all come up with similar sorts of things with regard to anal rectal malformations. And they'd all be about process, you know, how you would do this particular step or whether you'd do dilatations or that type of thing. If you were to ask 20 families what matters most, families generally will come up with very different things. And so we as clinicians wouldn't be in any way well placed to determine what people will come up with if they're a family member. Except, of course, we sit in clinics and we listen to what people ask us. But actually, if you do have questions for future meetings, then just say. But therefore, Joe and Cassie have built this session around what families in Australia have said. So if we can all just turn on our heads, you probably understand it better.
Hey, that's enough of that.
So, Joe was asking... These are... Oh,
yeah,
oh right. Very good.
They came from the support group, so we asked them in advance, and they all came through.
Great, very
So
good.
some of them will be from people in this room.
Super. So, what is a bowel management programme? Bowel management programme is a term that was used initially by Alberto Pena, who was somebody that we all look up to. He was a pioneer in this area, and he tried to systematise the whole process of caring for kids with anal rectal malformations. And he recognised when he was well down the line after doing the operations that you need to put in as much effort to the follow-up as you do to the actual surgery and preparation for surgery to get good outcomes. And the term bowel management programme was coined really through that process. And what it meant in the United States, certainly from the New York centre that he worked in, and then Cincinnati, is that it predominantly meant that there was a mechanism of doing washouts for kids that weren't doing well to get them clean. And for me, the primary issue is this. You want, I think, a child to feel that when they go to school, that they're no different than any other child in terms of, you know, their right to be there all themselves, and that their families aren't spending the whole time thinking about whether or not they're going to be continent when you really want them to be continent. Now, we heard this morning that, you know, it's not uncommon for primary school kids to have problems with continence sometimes, but when it becomes an overriding thing that affects your relationship with your child or the confidence of the child, then that becomes an issue. So what they started doing was using washouts very early on in the piece with the right support, with really good clinical nurse specialist support, with the intention of getting kids clean. I personally think, Joe, and I'd be interested in your thoughts, I think that you can achieve the same outcome in terms of being clean with doing other things other than washouts, and that's using laxatives in a particular way, and we use suppositories in a particular way. But the principle is the same. It's having a really proactive approach to figuring out what's stopping a child being clean, and then fixing up with the family, with the child, what the range of approaches is, and then allowing yourself to fail a little bit, and then picking up the pieces, and then moving forward. That's what my take is.
Ditto. And all I would add to that is that you have to start a programme somewhere, and then it gets individualised to the individual child. And I think that it seems like a fancy term, bowel management programme, but all families that I've dealt with want to understand is how can they get their child clean, and what's the mechanism behind doing that. So, yeah.
I didn't have bowel management when I was young. I used to call it trial and error.
Yeah.
And that's just similar. That's similar.
Greg's saying trial and error. It's true now. I mean, you don't always get it right first time. So that link that you have with the family, with the nurse specialists, and with the child, it's so important because it allows you to pick up early when things aren't working, but at the right level. Because sometimes things are never going to be perfect. So that takes real high order thinking.
So, what are the main types of laxatives?
Thank you for that question, Joe. There are really two types of laxative. There's one type, which we might call Movicol or Laxido, which gets stools to be soft, and to me, that's really all it is. The second one is a stimulant, which would work by a range of different mechanisms, usually we don't really know, which increases the motility or the squeeziness of bowel. And it's that simple. Now, I wish there was a rocket scientist or something. I mean, we've got a pretty simple job. And it's about selecting the right gear or selecting the right, shot or, club out your bag if you're playing golf. So if the stools are too hard for it to come out, then you need a bit of Movicol, right? If it's so runny that, it will be hard to imagine it staying in, then you're on too much Movicol. If the child hates you for trying to think of 31 ways to trick them into having 17 sachets of Movicol every day, then that's too much, right? It ain't going to work. The other one that I use as a stimulant is Senna, and I use Senna when I'm once the stool is soft enough. And the key for both of these is allowing the family ownership to regulate the accelerator or the brake. So if you say go up and down in 1 mil increments of Senna to try and get them to stool every day, that's a rule of thumb that I use. Maybe there are better ways of doing it. And the other way of delivering a stimulant laxative, if the hold-up is just inside the anus, then a way that a child may choose will be to put a suppository in, because that delivers a stimulant, a besocodal suppository that is, delivers stimulant to the area that you want it to work in. But of course that doesn't work if the hold-up's higher up. Okay, so does that make sense? It's not that hard.
I talk to families a lot about goals of treatment in using laxatives, and that, I think, for me is something about the age of the child. And in a child who would be in a time when they were normally in nappies, which would be up until about 2.5, 3, and they've had their reconstruction, they've been reconstructed for 1.5 years or so, the goals of treatment are just for them to be pooing regularly, effectively, and decompressing to the point where they've got good appetite, they're thriving. And then as they then get to the point where they're starting to come out of nappies, the goals of treatment change a little bit, and that's when I'm often using from just using something like Movicol to then adding a stimulant laxative, because I want them to have stool that's got enough form to it that will trigger sensation if they are able to have it, and then getting them to be able to make the transition onto the toilet. And I'll always get families to utilise those times in the day when their lower bowel wants to work. We have this reflex in our body called gastrocolic reflex, which basically means if you have a big meal, you need to go for a poo, because that's how your lower bowel works. I think of it often as just that there's a certain amount of space in your tummy, and if you just filled it with a big meal, something's got to come out in compensation. And so within that half-an-hour window, that's when I'm often encouraging parents to get their child onto the potty, onto the toilet, sometimes then using a stimulant the night before to enhance that natural reflex. And we often say that the bowel loves routine, and as soon as you can get children into that routine. And so I'm often making that transition from the softening laxative onto the stimulant laxative, or other methods to get the lower bowel to work effectively. Just a word on Movicol, I like it more than lactulose, which is another softening agent, but it requires fluid to be brought into the bowel by lactulose, whereas Movicol just keeps moisture in. Although sometimes lactulose is the only thing that you can give to a small baby, because they just don't like the taste of the Movicol. But lactulose is a sugar, it gets broken down, so it produces a lot more gassy effect in the tummy. And if children have got teeth, they need to brush their teeth, it's a sugar as well. You don't have that with Movicol.
There was a very good paper published from Mexico City a couple of years ago that showed pretty convincingly that overall Senna works better for children with anal rectal malformations than Movicol. And I completely agree with Joe that if you get the choice, Movicol over lactulose, but if you have to use lactulose, just make sure you look after the teeth. Long-term effects of laxative. So that really, to cut to the, sorry.
Michael's already on a laxative in his previous should I expect him needing a bit more help from laxatives after closure?
I missed, you said he's on, your son's on.
He's already on a laxative, but he's pre-closure. Should I expect him to need a bit more help after than usual?
You know, Joe, I like Joe's way of looking at it as sort of goal-directed. So, to me, it's a bit like if you have asthma. So, if you've got symptoms, then use an inhaler. So, sometimes you don't need laxatives after stoma closure. Sometimes you do. It depends very much on what the function's like downstream. So, I wouldn't necessarily say the two would necessarily correlate. Sorry for the whistle. Long-term effective laxatives. A lot of people were told in my generation that people get used to Senna in some way, but that, it turns out, isn't true. So I gather from someone that ought to know what she's talking about that comes from a study in 80-year-old plus ladies that was done in the 1980s, and it was probably the case that they were not being given enough Senna in the first place, which is why the dosage had to go up. So it was out of context to this, and I'm not aware of any evidence that suggests that people get stuck on Senna or the dosage goes up in that way. You get used to it. You don't get used. That's the same with Movicol, actually.
Yeah, there's some concern about Movicol. You may be aware that in the States there's a group called Mothers Against Movicol, which is a concern about some of the micro-constituents of Movicol crossing the barrier going into the brain of developing children. But actually, again, I was at a conference listening to a world expert in paediatric gastroenterology who's looked at the evidence base in the literature as is published at the moment, and that, again, that seems to be an unfounded concern. So at the moment, these still, as far as we know right now, appear to be safe drugs to use in the long term.
I've been on centre-based laxatives for 40 years now, every day, and I've had a recent colonoscopy with no issues at all. So for anyone who worries about the long term, you know, as I said, I've used them for 40 years.
Yeah. Question about
Is Senna seen as more safe than Inaugural? So did you rank them like Senna, then Inaugural, then?
Lactulose, yeah. Well, they both do slightly different things. In terms of safety, I would say that there's better long-term safety data for Senna than there is Movicol. Although I'm not saying that either are particularly unsafe, I would also say that the data just aren't that good anyway. We don't see a load of problems with either drug, do we?
But it just reflects the fact that Senna's been around a lot longer than the Movicol class of drugs that are called macrogols.
And where does sodium sulfate fit in with the... Because our son was on Senna and it just had to go up and up and up and up.
Yeah.
And then he was going into hospital with quite severe stomach cramps and being sick and almost passing out. So we were then transferred into gastro and put onto sodium sulfate. So it's just sort of, obviously every person is different, but where does sodium sulfate fit in to what you're talking about? You know, you've just talked about Movicol, laxative, Senna.
I mean, the class of stimulant drugs that Jonathan was referring to includes drugs like Senna, sodium picosulfate, bisacodyl. There are a number of them. So most of us start off with Senna because I think most of us in our training have got very used to that drug in terms of its effects. But there are second and third line drugs that we would try, and bisacodyl is one that I would usually go to as a second line drug because we use it in suppository form. We use it as part of our ACE washouts, which we'll talk about in a second as well. So got a reasonable amount of experience with that. But I think it's interesting how sometimes you'll have a child who just doesn't seem to want to respond to the Senna or get side effects with it, and then responds beautifully to another stimulant. So the message to our colleagues would be, if one's not working, there are others that you can try, and interestingly may have effect when the Senna wasn't working.
Yeah, that's very much the case. I mean, if you've got a right relationship and someone says drug X really isn't working but drug Y does, then you try drug Y.
No question.
Hi, yeah, just on the sodium sulfate, my son was on that because we were upping the Senna and upping it, and he had some quite severe bleeding episodes. I mean, we can't necessarily link it to that, but it pretty much seems to be. Is that something you've ever heard of, or were we just quite unlucky there, do you think?
I have to say, I haven't had that experience. I think, you know, we've got this little Bible that we use for drugs called a BNF, and if you read in the fine print of any of the drugs that we use, it's a long list of very frightening things, some of which are idiosyncratic. That word means that they're individual to the child in their response to that drug, and you wouldn't expect to see it across others. So it's certainly not something I've seen in 16 years of practice. I don't know whether you've seen that, Jonathan.
It's not something I've seen with sodium picosulfate, but I think I've seen it with Senna.
It could have been the two together, perhaps. I don't.
Maybe. I've certainly seen mucus with Senna, and so then you've got to say, honestly, we don't properly understand the mechanism of action. I've not seen somebody come to harm with a bad colitis off the back of it. So,
can I just ask about fibre? Because I know that in Colorado they use fibre supplements quite a lot as well, but we don't seem to do that so much in the UK.
Are we allowed to say things that make us look bad? That's probably the idea. There's something that I've seen two groups of people in the States do better than anyone that I've worked, and that's using things like Benny fibre. So that's titrating the different types of fibre that will bulk your stool up and do other things. Now, it's funny how, like, we do other things that they don't do and whatever, but I think that's something that I'd like to learn a little bit more about properly. So I think that, in short, fibre, yes, but knowing a little bit more about it and knowing how to titrate it would be smart.
I think they recommend, it might be the same paper, but I think Dr. Bishop wrote a paper about pectin in particular.
Yeah.
That's one as well.
Yeah, pectin it congeals stool a little bit as well. So if you've got loose stool that's difficult to keep in, it congeals it a little bit.
A slightly counter view to that is that I've worked with people who have been concerned about adding roughage and bulk to the diet for children when you're struggling with constipation issues and the ability to then stool. So you can find yourself bulking the stool by using those agents and then trying to make the stool thin by giving Movicol. So all of those things are fine to try, just don't find yourself in a position where you're adding two things that might be contradictory in terms of their potential effect.
At what point would you start a bowel management program? I mean, I know we don't have a formal start point in this country, like in America, but at what point in the child's sort of, at what age would you sort of sit the parents down, maybe at a clinic and say, listen, I think we should need to put something in now. I know you were talking about them being in nappies and then, you know, is it before school starts or once they're potty trained?
You kind of,
Once you want to start potty training? I don't know.
imagine yourself that you're the surgeon talking to brand new parents with a brand new baby that's got an anorectal malformation that's just had its colostomy. And you want to get across to them something about the projection for the life of their child. You may not have all of the information that you need. There's a point where actually you want to talk about what you're going to do today and not tomorrow. And so that's the very start of a long-term relationship where I was talking about goals management before, because every time we're looking at starting something that's got a goal in mind is the time when I want to talk to parents about that specific goal. And that kind of changes as the child gets older. Now, it's not to say if the parent said to me, what's my child going to be like when they're 16? Clearly you have to answer that question. You may not have the information to know it, but actually it's not as important as what the goals are for the next couple of years. So I think in short, an answer to your question, that starts from the minute the child's born. Your bowel management starts with giving them a stoma so that they can evacuate. And then your bowel management continues to ensure that they're decompressing effectively and thriving. And then the bowel management changes once they have the reconstruction, because I generally, for pretty much all children after reconstruction, give them some Movicol. But as Jonathan was said, give the parents a recipe to say, this is the goal that I want your child to be doing. This is the Movicol to use more or less of. If your child's got a diarrhea and vomiting illness, you're going to stop the Movicol. If your child's on a really hot sunny day and hasn't drunk that much, you're going to need more Movicol. But as long as they understand what the goals are, they are then empowered to then use that Movicol and the diet and fluid intake to share the goals that you have.
And there's something else we're supposed to do, which is be loyal to our patients rather than to other staff groups in whichever hospital. And just on the bowel management programme thing, I really do respect Dr. Pena. But sometimes I wonder whether or not this whole entity of bowel management programme is perhaps more relevant in the United States, where you have to sort of get funded by insurers to go over to have something done as an entity, whereas here, just as Joe says, it's a continuum. It should always be there. It's a goal-directed thing, and it's just dead logical. What we should do is get ahead of the curve, be clear about what we're trying to achieve, and be proactive at trying to achieve it. So completely support what Joe says.
In very quick answer to this question, just because a child's got an anorectal malformation, it doesn't mean that they may not also have other things that affect the bowel. If you look at things like ordinary constipation, which is rife within all children, particularly in the UK because of the rubbish diet we have, and probably worse in North America, but they may have intolerances, they may have inflammatory conditions of the bowel, as well as their anorectal malformation. So I think there are specific things on top of that for which we've got a big gastroenterology department that we would involve them. We may come on to talk about ACEs and sometimes why ACEs don't work, and a need to then look at how the upper bowel is working other than just the anorectal part. Again, may need further investigations through gastroenterology, but I guess for the most part I would assume that most families with children with this condition, you're coming to the clinic, you're seeing your surgeon, but you're probably not seeing a gastroenterologist, so I think it still remains something for us to manage.
And I think we've got five minutes left of this section, and there's no thoughts. So I'll just very quickly do this, and we'll get on to Joe's bit. How much should the child be pooing right now? Well, Joe's covered that in terms of enough to grow when they're in their teens, when they're out and nappies, to develop a degree of continence that's optimal for that child. At what stage post-reversal and what is right? Well, that's why you have nurse specialists, you know. You don't need a surgeon trying to give you a blanket thing, but it takes a few months to settle down sometimes, but then when you're a few months down the line, that's enough, you know. You don't want to be waiting 2, 3, 4 years and still trying to limp along. Should you worry about constipation, blowouts and the right amount of poo or not? Sometimes it's just as important to know that everything's actually okay, or is as good as it's optimal. Do you know what I mean? So, you know, lots of kids have got tummy problems, but we've got to be smart enough to know when it's related to the anorectal malformation or the drugs. You know, that's what we need to do.
Can I cover the first part, really?
Yeah. So the next title, problems with moving, gas and pain, what can help this? Depends what's causing it. As Joe said, you can have other problems that can cause it. But equally, some families may feel strongly that it's to do with the drugs that they're on, and you may be right. What we have to do is to figure that out together. Joe?
I wanted to be a heart surgeon or a brain surgeon, but actually I'm a backside surgeon, so you just don't always get what you want in life. I think what we understand, continence is a thing that relies on two important parts. One is nerves, and primarily we're talking about the nerves that come from the lower spine that travel to our sphincter muscle that enable us to know how to squeeze it so that we can still get home when the bus from Tesco's, yeah? And that muscle has two parts. One part is the bit you don't have to think about so you can go to sleep at night, and the other is the part that you do think about. And both of those muscles are affected to a greater or lesser extent for children with anorectal malformation. And as I mentioned, the nerves also that come down from the brain, so if your child has a background problem that affects their main nervous system, squeeze it, or they can't determine the difference between solid, liquid and gas, which we can all do. If you ever think about that, you can be pretty clear about what's going to come out of your bottom, and children with anorectal malformation can't. So if we're going to keep the child clean and not continent in that sense, then we need to get the bowel to do what we want it to do, when we want it to do it, and then not have anything happen in between. And again, we're talking about goal-based management. Now, the colon can be made to contract, and to do that, you can distend it by putting fluid into it, and that's essentially part of the systems of irrigation. By putting fluid, even simple fluid like tap water into the bowel, will distend it and cause it to squeeze. You can irritate it, and sometimes irritation is by putting in a simple suppository, just like a glycerin suppository. It doesn't have any active drug in it, just irritates the lining of the bowel and makes it squeeze. Sometimes you get irritation if you've got an infection, and that's how that infections make you go to the loo a lot. And then you can stimulate it. As Jonathan was saying, we use stimulant laxatives by mouth, but you can also put stimulants directly into the bottom as well. So it's trying to find a system that will work on that principle, that's going to get the child to have at least one, if not two, good, efficient bowel actions in the day. That's going to mean that for the rest of the time, even though their nerves and their muscle at the bottom isn't working, nothing's going to come out. So they can be out of Pampers, they can be in normal underwear, they can do all the stuff that they want to do, enjoy their life. So how you do that is a little bit based on what system you're going to use. If you're going to put a suppository or a little enema into the bottom, it's going to stimulate that part to contract, and it works quite quickly. If you're going to use any of the transanal irrigation systems, like the one we've seen outside, Peristine and Cufora, you're probably going to get this part of the colon empty. And on the basis that your colon will fill up about every 36 to 48 hours, depending on how well it's squeezing, that will give you relief for that day. If you're going to use an ACE, which is antegrade colonic enema, you're going to put it in at the appendix, and that's going to flush out the whole colon. You may get 2 or 3 days of nothing coming out of the bum if you're using that system. And none of them are mutually exclusive. So, anal colonic irrigation systems alternatives, how do they work? They work by hydrodistension, by putting water or fluid into the bowel, which causes it to stretch. That induces contraction, it lubricates the poo that's there and gets that all to come out. These are the systems that are used. This is Kufora. Hands up anybody who's using systems like this? Okay. It's often said, and we have a colleague from France here, but we're a little bit anal retentive in the UK. And I've got colleagues who are from Italy and from Germany, and putting things into the bottom is part of normal medicine and care for them. Whereas for us, it's a kind of, we're not going to do any of that. So it's a surprise to me sometimes how they can be a little bit resisted by parents, because the concept of putting something into their child's bottom is not something they've grown up with as a way of introducing medicines. And until families actually see what the systems are like and how manageable they are, there's a, how on earth am I going to do this? How do I, I'm in the bathroom, it's going to be all over the floor, it's going to be in the bath, just the whole logistics of it is something that I find puts families off until they've tried it. And we've got a rep who works for Peristine, which is this system, who will actually go into the families' homes and introduce them to the system, and I think that's once you've seen the effects of these. And colleagues of ours who work at the Royal London have a big cohort of children who are using this system for ordinary constipation outside of anorectal malformation. So I think that we're seeing the birth of a lot of transanal irrigation systems. I think these systems will get better, they'll get much more specific for children, and I think in the future they'll be really very effective. And
the only thing that I think I'd add to that from just watching over the years is the word invasive. Invasive is something term that we use. Actually, it's not really for me as the doctor to determine whether it's more invasive to have a tube in a patient's bottom or a tube placed surgically here, or to have problems with accidents when it will bother me but might not necessarily bother the child or the family. It's not for me to determine. So actually, one of the great things that we have is we've got really good nurse specialists that will take families through outside the clinic scenario and just go through what the different options are, what the different ways of doing washouts are. So they'll do talk similar to what Joe's done, and just let kids handle the equipment and get their head around it without it being a pressure to sell, if you know what I mean.
Sorry, just very quick, what age are you sort of recommending and socialising the ideas with the children?
That's a fascinating question, because there are phases of development for children that I think match their physical and psychological development and the need to intervene. So imagine most children up until the age of 4 or 5 are quite happily living their life in nappies, in Pampers, and they don't care about the world, they just care about what's on the Cartoon Network. And it's comfortable for parents because they're at home or they're in nursery, which are coping with children with nappies. And then this big thing called school arrives, and the trauma that creates in families is intense, because all of a sudden you're having to put in place all of the systems to allow your child to be cared for and toileted at school that you were doing at home. But actually the child themselves isn't that bothered. Yeah? When the child gets a little bit older, we're talking sort of 7, 8, 9, actually they're becoming very aware of the differences between themselves and their peers. And the reason why I think that's important is because it's often a time of a need for psychological support for the parents at that early stage and then the child themselves. But it is often a fruitful time to look to intervention, because the child is becoming aware and cooperative and can be a partner in their treatment, because they understand or are starting to understand the goals of treatment. And so I think for me, there's probably no point in introducing these symptoms in the preschool child, because I just don't think you're going to get the involvement of the child, and you kind of risk pushing them away a little bit. And so I think for me, 6, 7, 8 onwards, particularly the ACE, if you're going to use an ACE on a child, that's quite a lot of involvement, quite a lot of time invested in getting that right, and I think you do need some understanding and involvement and partnership, not only with the child, the parents is guaranteed of course, but you need that from the child. Jonathan, what do you think?
I think I'm scared of Cassie, who's done that, and Beck's done that. Would it be okay if I came to find you at the break, and then there's a gentleman over there we came to find?
Question and answer session right at the end, isn't
Oh
there?
yeah, we'll do it then, and then maybe we can pick up Joe's point then as well.
Yeah.
Right.
Okay.
Thank you.
We've got to sit down.
Yeah.
We've got to sit down.